The final presenter for today is Michele Cree. I've known Michele for a long time. She was a very good mentor to me when I was just but a baby pharmacist and spending some time as an intern at the Royal Children's Hospital. And she was one of those people that got me inspired about intensive care medicine and made me decide that I wanted to be an intensive care unit pharmacist, but just with big people. But the reason I'm telling you this is not just to highlight what a fantastic influence that Michele is on many people, but also that she is very experienced. And it's very exciting for her. And I think that the whole area of optimized dosing in critically ill paediatric patients, that someone as experienced as Michele has decided to undertake a PhD on this very important topic. And it's a PhD that's going very well. I'm sure we're going to learn a lot about all of her learnings over the journey of her PhD so far. So I'd like to welcome Michele up to give the final presentation about paediatric dosing considerations in renal replacement therapy and ECMO.
I don't know if you can you hear me? Yeah. So thanks, Professor Jason Roberts, I will say, for allowing me to, for the invite and the participation in the Antimicrobial Optimization Education Series. So, wrong way. So I have nothing to disclose or declare in regards to this presentation. So firstly, I'm going to talk about pharmacokinetics in children. We've talked about adults, but children aren't small adults, as we all know. They have, firstly, the pharmacokinetics. We talk about the drug is distributed and eliminated in the body, which is the main things that we're looking at. Kearns talk about here about the different variabilities that we can see, and I'll go through those individually, looking at the distribution and the elimination. So distribution, we can see significant changes in the body composition. We know that in infants, they've got a higher extracellular water, which affects the hydrophilic antimicrobials with a larger volume, affecting their volume distribution, whilst lipophilic antimicrobials have a higher volume distribution, and the infants also have a higher fat composition, again, affecting that volume distribution compared to older children. We also have higher gastric pHs in infants, so that can affect how a drug is actually, the drug disposition. We also have here lower albumin. So in that perspective, we're going to see lower protein binding, especially like for ampicillin, which is a drug that's used in neonatal sepsis, where they'll have higher free plasma concentrations, and then you'll result in a higher volume distribution. So we don't give it as frequently. We also have lower hepatic enzyme activity, and that impacts that we may give a lower dose milligram per kilo in newborns compared to infants, child and adolescents. And then we've got lower transporter activity, which also impacts. So again, you might give, in some cases, you might end up giving a higher dose. Excretion, if we look here, we've got an immature renal function, so that can actually vary as we grow, which is shown in this graph here of over time. You've all talked about pharmacokinetics in antimicrobials in PICU, and Claire and Haviz have talked about some of the critical illness. So I'm not going to go into that in great depth, but just to highlight that we have got a higher incidence of in our critical ill children with the use of co-medications of causing that augmented renal clearance, which is going to be problematic in how making sure we actually get optimal dosing here. And then we're just going to talk about extracorporeal organ support here. So we have that is an infant, a neonate, a term neonate there. You can see, well, maybe you can or you can't see the child. You can see the extracorporeal therapy and all the machines, a lot of technology about that poor little infant. So as Haviz has talked about, it ECMO provides respiratory and cardiac respiratory support, whereas your renal replacement support provides the kidney support. And additionally, which I'm not going to talk about, is the molecular absorbent recirculating system, which provides liver support, but we don't offer that here in Australia. So ECLS is just going to be referring to, in this presentation, to ECMO and CRRT. So mortality for infection in critically ill children. Globally, the mortality from severe infection in the ICU is 26%. That's equivalent to 4 million deaths a year, a startling statistic. And certainly we know that 15% of these will require extracorporeal life support. So 10% require renal replacement therapy and 5% requiring ECMO support. So we need to try and work out how we can actually make these children survive, or all of them survive would be ideal. We know that the children that present with ECLS are the sickest kids in the unit, where they have 1 in 2 chance of survival. So we do need to try and look at how we can improve that. Mortality is unfortunately increased if they actually develop a nosocomial infection, where they actually have a higher than 50% chance of mortality. And again, if they develop an invasive fungal infection, it increases also by 10%. So if we look at changes of ECLS in critically ill children, we've got altered pharmacokinetics, generally with developmental and every other aspect of that, but we also have it different in children in some of the data that we'll see later. The circuits are very different than what's used in our adults. They have different filters, different oxygenators, different volumes. The priming volume relative to the child is very different. So a neonate might have a volume of about 250 mils if they're about 2, whereas you might prime the circuit with about 370, equating that it's 600 plus mils, which is nearly 3 times their actual total circulating fluid. So we're dosing that. What are we actually dosing them for? We're dosing them for the fluid volume, or what are we actually doing? The other part here is we've talked about is the organ maturation, which we spoke about. And again, unfortunately, there's limiting or conflicting dose recommendations available. So here Zimmerman talked about the effect of ECMO on drugs. Now, this was in looking at paediatric data. We can see the drug sequestration is in the main avenues in the blood pump, the tubing, oxygenator, and the heat exchange. And that depends too on the composition of the oxygenator, and that will vary as well. So Haviz has talked about if they're lipophilic, increases in protein binding, high protein binding. But the other part we need to worry about is really that priming volume in our small children. The percentage of medication recovered in ECMO at 24 hours compared to the medication lipofacility is also represented here. Now, this is paediatric data where we can see here in the ex vivo, vancomycin really showed no loss at all. And whereas cefazolin and epicillin, highly protein bound, but again, hydrophilic, and really didn't show a great loss, about maybe 10%, whereas voriconazole showed some loss here. We know it's lipophilic, it's moderately protein bound, so you would expect that sort of aspect. But do we actually see that in the patients, which we'll see later in some of the cases? So the potential effects on renal replacement therapy. We can see here we've got coagulation, we've got surface area options. The hemofiltration fluids are very different, and what they're used in children, but the primary aspect is the ultrafiltration rates are different. We use very much a high flux filtration rates in our children to try and help and eliminate the fluid from that basis. We have different tubing and filter size we talked about, and that can affect sieving coefficient and the drug sequestration. Again, we've talked about patient factors and drug factors. So here, this slide's been adapted by Shakira, looking at changes in ECMO and CRT in critically ill patients. So primarily, you can see that we can get an increase in volume distribution, which can happen that results, or an increase in clearance resulting in the therapeutic failure. Whereas if you're actually getting a decrease in clearance, more associated with the organ dysfunction, that you're actually going to have a higher risk of toxicity. So we really need to look at dosing that needs to account for the pharmacokinetic changes to prevent suboptimal dosing and treatment failure. So dosing recommendations for critically ill children supported by ECMO or CRT. So we've got here, Siderman looked at this from a PK alterations for children in ECMO. Here, they looked at 41 studies, including 23 medication. 13 of these were antimicrobials, where they found an increase in the volume distribution of cefotaxime, gentamicin, piperacillin, tazobactam, and fluconazole, and microfungin. They also found a decreased volume distribution was reported in 2 antivirals, acyclovir and ribavirin. For clearance, it was noted that it was lower for gentamicin, ticagrelor, and clavanic acid, and a higher clearance was reported for caspofungin and microfungin. The limitations of this publication is it didn't always compare ECMO pharmacokinetics with children that were critically compared with children that were critically ill, not on ECMO. So it's difficult to make comparisons on that basis. Another study by STIT looked at dosing recommendations and looking if they address the pharmacokinetic and pharmacodynamic targets, especially in continuous renal replacement therapy. There was 18 studies that they looked at with dosing recommendations for only 8, and 19 included antimicrobials. Of these, 8 antimicrobials, only cefepime and clindamycin had complete agreement with dosing recommendations and aligned with primary literature, whereas 3 antimicrobials had agreement with the recommendations, but 3 had no agreement with the recommendations, and they were fluconazole, piperacillin, and ceftolozane, while 3 others, vancomycin, meropenem, and linezolid, had multiple dosing regimes suggested in the literature, with some of that partially matching the recommendations. So the issue, the main thing that they found with a lot of the studies, that the patient numbers were actually less than 5. And finally, Dubisky looked at and conducted a systematic review where they looked at 35 articles, described the pharmacokinetics of the antimicrobials. Here, they looked at volume distribution and total clearance and found that volume distribution was similar, and 2 children that were critically ill, receiving or not receiving CRRT. They suggested that the renal protective dose adjustments may result in subtherapeutic dosing, and the article concluded that hydrophilic antimicrobials with low protein binding had a higher clearance in critically ill children supported by CRT. The problem with the actual article talked about limitations were mainly that the patient groups were huge variability. The CRT modes were variable, the filter membranes were not consistent, and ultrafiltration rates and blood flow rates were also not consistent as well, so making it difficult to make comparisons. So PK changes need to be compared to PK changes in critically ill children, and dose recommendations need to be based on PK/PD targets. So Valentino also tried to develop some pharmacokinetic changes in of antimicrobials. This table here was trying to describe the pharmacokinetic changes that were seen and recommendations of what they might do. How you can see here mainly the beta-lactams. I'm just highlighting the options of either looking at its in fact affect the actual pharmacokinetics. What they did find was that most of these studies showed that they had subtherapeutic concentrations. Noting this table has been based on Sitterman's review and previous reviews, which we're not comparing it to critical illness. So we do need to take it with what it is. And what they did actually conclude was that that we should be looking at individual therapeutic drug monitoring and adjusting according to what's actually happening with the extracorporeal system. So suggesting that we need to factor that in our dosing. So pharmacokinetic studies here, we looked at the studies that are available in ECMO. You can see there's not a huge amount. The cefepime vancomycin studies were in critically ill neonatal and paediatric patients, whilst the studies of ceftaxime, fluconazole, micafungin and piperacillin are in a combined population, so neonates and paediatrics, so they're not a unique part. But what we did find is the volume distributions were increased for gentamicin, micafungin and fluconazole, noting that most of those were in neonatal group. Which may be a reasoning for the increase of that part. What we did find here is that the voriconazole had a decrease in volume distribution, but that is only in 2 cases, which we'll talk about in the presentation later. If we look at clearance, we can see that meropenem actually found an increase in clearance in the studies, whereas piperacillin, vancomycin, cefepime had a decrease in clearance. A majority of those patients were presented with significant renal dysfunction, so that may be actually associated more with critical illness than actual ECMO itself. If we look at CRRT, the same options, we have still not many studies, but again, you can see that there's been an increase in volume distribution for vancomycin, daptomycin. Noting though, the daptomycin was only in 1 patient, and that's in an 8-year-old, so really that's all we've got. There is only 1 study in vancomycin, again, not a great deal of information, but that's all we've got to look at. Whereas the cefepime and ceftaxime really just showed a decrease in volume distribution as well as clearance, which is consistent from that part. So now if we look at vancomycin, so we know that vancomycin is hydrophilic, it's moderate protein bound. There has been studies in ex vivo reporting 38% loss, but zimmerman reported no loss at all. So it may be more associated with the oxygenator than anything else from that point. We'd know in the neonatal studies that we looked at that there was no difference in pharmacokinetics, but in the paediatric studies, there was an actual decrease in the clearance in the ECMO group. And we also know that 50% of those patients did not achieve the pharmacokinetic and pharmacodynamic targets. They did propose doses. They haven't tested those, but they did propose doses of using 25 to 60 milligrams per kilo per day. And looking at a lower maintenance dose, whether that in that particular study. And so Moffitt study looked at giving specific doses, like for the neonates doing 25 milligrams per kilo every 18 hours, infants 30 milligrams per kilo 12 hourly, a child at 25 milligrams per kilo 12 hourly, and an adolescent 30 milligrams per kilo 24 hourly. And in the renal replacement therapy, we only had 1 study, and that was done by Moffitt et al. As well. They looked at the trough prior to the 4th dose. They were dosing at 15 to 25 milligrams every 8 to 12 hours, and they resulted with a C-min of about 11 milligrams per litre, in concluding that most of these patients did not achieve their target because they were aiming greater than 15 milligrams per litre. So they noted they had an increase in the volume distribution in the CRRT group, and they proposed looking at perhaps a loading dose in that in those group. Currently, we don't do that in our practice. So the main thing is they looked at individual recommendations were individualised therapeutic drug monitoring, looking at either targeting the AUC or CMIN to try and achieve the best goal for them. Now, if we look at voriconazole, it's a unique drug. It's lipophilic. So it has moderate protein bounding. It's got non-linear pharmacokinetics. And you can see that in this graph here, where what you give a dose and what trough concentration. Good guess on that perspective. So you can see what you might actually get. So it's not predictable. So here in adults, subtherapeutic plasma concentrations have been noted, and they've recorded an increase in volume distribution. There was only 2 pediatric cases that we had here, one in a 5-year-old and one in, in a 5-year-old and one in a 17-year-old. When we looked at that, the volume distribution in critically ill children, it was actually, this was actually lower in the ECMO group. Noting that though, in the 17-year-old, we did actually look at the volume distribution when they weren't on ECMO in that study, and that's where it actually did have a lower volume distribution in the critically ill patient when they were compared to the ECMO. So that supported the adult data. So I think there's a lot of interpatient variability, and we really need to take into account the age of the patient. We know that children actually are higher risk of subtherapeutic doses. Males also have a potential risk, albumin and co-medications like proton pump inhibitors. Certainly one of the studies recommended that the standard dosing of 12 hourly may need to look at giving it that 8 hourly. So again, individualising therapeutic drug monitoring and addressing the interpatient variability. So we now look at meropenem. So in ECMO, the paediatric pharmacokinetic studies here, they dosed at predominantly 40 milligrams per kilo every 8 hours, infused over an hour. They noticed an increase in clearance in that. Unfortunately, in all of those, there was greater than 50% didn't achieve the targets, pharmacodynamic target. They proposed giving 40 milligrams per kilo every 8 hours over 3 hours, or looking at increasing that maintenance dose. In one of the studies by Cieto, he suggested even dosing up to 100 milligrams per kilo every 8 hours and infused over 3 hours to achieve that 100% above the MIC, time above the MIC. There are 2 cases that were reported in critically ill neonates on CRRT and ECMO. Very difficult to draw conclusions if they had altered pharmacokinetics, because we had no comparative aspects in critically ill neonates for meropenem. There's nothing out there. So if we now look at CRRT, so the paediatric pharmacokinetic studies, they looked at dosing at 10 to 40 milligrams per kilo every 8 hours. And what they found was there wasn't a significant amount of changes in pharmacokinetics. However, in a lot of the studies, they didn't achieve the pharmacokinetic and pharmacodynamic targets. And they proposed a dose of doing 60 milligrams per kilo per day, and really considering that you would do the same dose that you would do for a critically ill child. So again, individualising therapeutic drug monitoring is probably the way to go to ensure that we get optimal dosing. So what are we doing? Might as well do some part of self-preservation. We're doing some ex vivo studies for common antimicrobials. We're trying to look at the drug sequestration extraction onto the paediatric ECMO circuitry. We're looking at the clearance and absorption onto renal replacement therapy. We are doing some clinical pharmacokinetic studies, and we're trying to determine the volume distribution and clearance of common antimicrobials in ECLS, and with the aim of trying to address that pharmacokinetic and pharmacodynamic targets and outcomes and safety. So how do we manage dosing of antimicrobials in critically ill children on extracorporeal therapies? I think we need to consider the pharmacokinetic changes, the composition of the ECMO oxygenator, and potentially the priming fluid and the impacts that will have on increasing the volume distribution, which on both ways. And then the configuration of the continuous renal replacement therapy. As I said, we use a lot of high flux filtration. So we're trying to, we need to take into account the impacts of that on increasing the clearance. And finally, we need to look at pharmacokinetic and pharmacodynamic targets, and ideally to have real-time therapeutic drug monitoring to address for all antimicrobials. Questions? And that's my email and Twitter feed. And thanks. Do I go to